We now are going to start about how we can handle cases where we have a reduced periodontitis, but to give the chance of having a natural abutment for immediate provisional and also to get enough blood supply. So we need to keep teeth with a guarded prognosis, at least for the initial phase, in order to have a better provisional phase. So I removed the endodontic cyst, I did the full thickness flap, I used the new Nobel Biocare membrane, which was launched a few weeks ago in Europe. Number 10 was extracted, immediate socket preservation was performed, all in the most coronal part, just to compensate for a natural bone collapse. The cyst was removed. Now we have to deal with this kind of defects. So the three bony peaks are following in three different planes, three different directions. This is an ideal candidate for guided bone regeneration rather than intramembrane block graft, because the recipient bed is very regular. So we need to focus the attention also on the entrance of this lesion. That's the time it was removed, the endodontic cyst. The canine has a fair prognosis, periodontally speaking. Of course, there is a 30mm attachment loss on the straight buccal, 11 on the mesial, but I have a nice healthy periodontium on the distal and on the palatal. And the reason for which we had this kind of attachment loss was due to a traumatic extraction and the presence of an endodontic lesion. We don't have periodontal disease on this tooth. So the potential for tissue repair are really high. That's why this tooth has a fair prognosis. We cannot say the same thing for the central incisors. That is going to be kept after apicectomy only for providing a nice blood supply. We lost, of course, periodontal tissue, so we're losing 1/3 of a possible blood supply coming from the periodontal. A four-wall intrabony defect, which has a great potential for tissue regeneration. And I have another source of blood supply for the guided bone regeneration. So now we can start the second surgical phase. I don't have infection anymore. The purpose was to rebuild the sites for placing the implants in area number 7 and 8, 6 to 8 months after guided bone regeneration. At the same time, an implant in area number 10 was placed. So everything starts from the understanding of the biology. We go back really to the basic principles of the blood supply and what we can do in order to augment the sites in a very predictable way. We did the scan route planning before raising the flap. We want to detoxify the surface. We want to have a very nice and healthy tissue before raising the flap. We did all the partial thickness flap in the papilla in this area, and we extended distally because we wanted to place implant also in area number 10. We removed the degranulation tissue, which was, of course, formed after a couple of months, and now we need to kept after apicectomy only for providing a nice blood supply. We lost, of course, periodontal tissue. So we're losing 1/3 of a possible blood supply coming from the periodontal ligament. We need to evaluate during the surgical phase where the vascular supply is coming from. We have two sources now, the endosteum and the periosteum. So I want to maintain every single bony peak for my bone augmentation procedures. The blood periodontology. And then there is also an aesthetic issue. We need to evaluate during the surgical phase there is a discrepancy coming from. We have two sources now, the endosteum and the periosteum. So I want to maintain every single bony peak for my bone augmentation procedures. For the canines, the blood supply is also important to get a vertical ridge augmentation, so we need to increase the length. When we start looking at this case from at the time of cyst removal and 2 months after, we can see there is already a newly formed bone here, the most extending palatally, for about 1 centimeter four-wall intrabony defect, which has a great potential so we need to understand which kind of anatomy of the defect, which kind of morphology we have to deal with in order to plan also our So now we can start the second surgical phase. I don't have in this patient we can distinguish the purpose different surgical phases. The initial one has placing the implants in area number 7 want to eradicate the endodontic lesion after Gadibo regeneration. We want to remove the granulation tissue. An implant in area number 10 need to prepare the sites for a future bone augmentation. So everything starts from with the understanding of the biology. We go back really to the basic principles of the blood supply. There is a periodontal pocket that mesial to the canine. What we can do in order to augment the sites in a very predictable way. We did gingival replacement before raising the flap. We want the same family the surface. We can have a disease periodontal. This patient, for example, we have a very nice and healthy tissue before raising the flap. Was attempted about 15 years before I saw the patient. We have a verti-horizontal deficiency due to a traumatic or a disease periodontal. We did all the partial thickness flap in the papilla in this area. If we start looking at this clinical example, distally, because we wanted to place implants in our treatment strategy on diagnosis. We removed the granulation tissue. There are so many different reasons after a couple of months, and now we need